Good morning once again, and I'll be speaking on the corneal collagen cross-linking with riboflavin. So now we have kind of realized, we have known the etiopathogenesis, pathology, and then the diagnostic design for keratoconus. We're starting with the treatment modalities, and I'll be offering the most innocuous kind of treatment modality available for keratoconus, and that is C3R. In various acronyms have been given to it: C3R, CXL, CCL. Keratoconus is asymmetric, bilateral, progressive, non-inflammatory ectasia of the cornea, and incidence of case keratoconus is about 1 in 2,000 people, which is approximately 0.05% of the population, and starts in the second decade of life. Form first keratoconus is, when the progression stops in these cases early, and this is found in approximately 5 out of 1,000, and this is also quite frequent. The iatrogenic keratectasia, which we see, is not so, the data is not available because of paucity of reports regarding this, but we know that there is a possibility of these things, and then we are, kind of trying to go ahead and diagnose it before, so that we do not have a post-operative keratectasia. Exact cause is not clear, but it can cause slight irregular astigmatism and also severe irregular astigmatism and severe visual loss. And diagnosis has been, talked about already. The pentacam happens to be the gold standard for the diagnosis of keratoconus, which will give you all the indices which have been talked very clearly by Dr. Rajiv Mukherjee, and I'll go forward from there. And corneal collagen cross-linking decreases the progression of keratoconus, and also it decreases the corneal thinning process. It predominantly affects the anterior 300 microns of the cornea. It stabilizes the corneal architecture. Beneficial effects on corneal optics and vision results in improved corrected distance visual acuity and uncorrected distance visual acuity, and also improves the maximum and average keratometry values, which becomes flatter as we have seen over the period of last, say, 16 to 20 years. There are several corneal topography indices which improve, and corneal and optical higher order aberrations also improve and reduce. Yeah, thank you very much. So this is one picture which is seen so many times everywhere whenever we talk about keratoconus, and this is showing the hardening of cornea after C3R. And this is the crux of the whole treatment of corneal collagen cross-linking. The inventors are, everybody knows, Theo Seiler, Spohl, and Wollensack. And what physiological process which happens after cross-linking is stiffening of connective tissue, and this is also well known in diabetes and aging, and diabetes is a protection factor against keratoconus. During cross-linking, new chemical bonds are formed which make the cornea more strengthened and harder. Indications for corneal collagen cross-linking are keratoconus, as we all know, and then other indications are periostid marginal degeneration and iatrogenic keratectasia. The requirements are at least one diopter of steepening over 1 year, so there has to be a progression very well documented for corneal collagen cross-linking to be applied on that particular cornea. Corneal thickness at the thinnest location should be more than 400 microns, and ideally it should be nearly 450 microns, because what we are doing is we are removing the epithelium, and then we are putting the riboflavin. And then maximum corneal curvature up to 60 diopters. So this is the minimum requirements. And goals of the ultraviolet cross-linking treatment is to stabilize the cornea and to stop the progression of the disease. Now, patient positioning is very, very important. It has to be absolutely parallel. There has to be, beam aperture has to be absolutely parallel to the cornea. And treatment plane is approximately 5 centimeters away from the corneal surface, and the area of exposure and area of the image on the ultraviolet image on the eye should be very smooth and very uniform and very circular, and not like too close or too far like shown in these pictures. What the treatment steps are: we put pilocarpine 2%, 1 drop 30 minutes prior to the starting the UV treatment, and this is to keep the pupil constricted during the treatment for next, say, about half an hour to 60 minutes. And this is precisely the because the ultraviolet rays should not enter the eye and damage the lens and the retina. It is done under local anesthesia. There is a manual epithelial abrasion of 6 to 8 millimeter as to whatever size you want to expose to the ultraviolet. You can use a excimer laser also to remove the epithelium. Every 3 minutes a riboflavin solution is dropped for approximately 30 minutes, and then you must see the patient under slit lamp to see that there is clear fluorescence within the antechamber. Then irradiate the cornea with UVX depending on the voltage you're using. It can be from 30 minutes to 8 minutes, 6 minutes to 5 minutes. During this irradiation, the riboflavin solution is dropped every 5 minutes, and every 2 minutes there is a drop of BSS to be put on the cornea to keep it hydrated, because most of the time the riboflavin when you put becomes slightly dehydrated, and this has to be all the time visually controlled. So this is the manual abrasion, and here it is a abraded manual deepithelized cornea, which is in the form of 4 or 5 horizontal and vertical lines. And then there is putting the riboflavin solution over the cornea, and then ablation, and you can see what kind of ultraviolet images, ultraviolet light is being exposed on the surface of the cornea. How much ultraviolet light goes into the eye? You can see these pictures, and there's hardly any thing which goes beyond 400 microns. It is hardly 6%. And on the right side you will see the amount of light which goes inside, and the left side you will see as to what is the damaging percentage to that particular organ. And it is much less than what we are doing. So this is caused by riboflavin shielding. Now, combined application of ultraviolet and riboflavin will reduce oxygen radicals. This oxygen radicals will induce the collagen crosslinks and form the collagen fibrils within the corneal fibrils. And this is what we are seeing in the initial phase. There is loss of keratocytes in the initial phase up to 300 microns, and then repopulation of these keratocytes takes about 6 months. So in 6 months time, all the keratocytes have regenerated, as you can see in the confocal microscopy here. So corneal thickness has to be more than 500 microns, and optical device has to be without any hot spots, and thereby we can reduce the progressive keratoconus into a formless keratoconus by collagen cross-linking. Now, complications of cross-linking is haze, scars. Sometimes there is endothelial damage. There might be a treatment failure, though I have not seen any in my own cases. There could be some sterile infiltrates, and of course, the important fact is that it can cause herpes reactivation. So, a modification in thin corneas is you can use hypotonic riboflavin solution, or you can use selective epithelial removal, or you may use transepithelial collagen cross-linking. LASIK extra is when there is a need, there is a feeling that this particular patient can develop keratoconus after ectasia, after the LASIK procedure, and it is a high risk case. Then we can do after removing of the flap, after lifting up the flap, we can put a riboflavin solution, wait for about 2 minutes, and then expose this thing, do the UV radiation for about a minute, and that is sufficient to stop this complication of ectasia after LASIK. Accelerated cross-linking this has revolutionized the standard cross-linking by reducing the treatment time from 1 hour to 3 minutes or less, because as soon as you have put the riboflavin on the cornea, you can expose with a higher voltage, like for instead of 30 minutes, you can expose it only for 6 minutes, and it gives the equal effect. So that is the new thing which has come in, and this is works wonderfully well. And the amount of cross-linking which occurs in the cornea is shown to have the same effect as after 30 minutes. Now, intrastromal cross-linking is a non-surgical refractive correction with accelerated cross-linking alone. It causes the flattening of the cornea and thus removes a little bit of myopia. This is indicated in cases of post-cataract ametropia and for very, very low myopes, where a little bit of flattening of cornea will take care of the refractive error. In conclusion, in a cornea which is 400 microns or more, a progressive keratoconus can be transformed into form first by corneal collagen cross-linking. Thank you very much.